So topic today of my presentation is treatment of post-irradiation Cricopharyngeus dysfunction in NPC patients. Indeed, dysphagia is a very common problem in history of NPC. It is estimated that 1 in 4 patients will have this complaint. However, this is a difficult problem to be treated because it is involving a multi-level anatomy. Patient may have tongue-based atrophy, pharyngeal incompetence. There may be an absence of swallowing reflex, poor pharyngeal constriction, and leading to pharyngeal residue retention. Compounding with vocal cord palsy, patient has a high risk of aspiration or even aspiration pneumonia. So this is one of the common scenes that we see. Patient has a non-functional larynx where a tracheostomy tube is in place for bilateral cord palsy, and a feeding tube is required to ensure a safe oral intake, a safe intake of food. So today I would like to focus on 2 problems, the poor pharyngeal constriction and the pharyngeal residue retention, which is estimated to be at 80% in this 1/4 of patients who complain of dysphagia. With these 2 problems, it is classified into the Cricopharyngeal dysfunction. The reason is that the Cricopharyngeus is a muscle bordering the hypopharynx and the upper esophagus. So with a patient who had weak pharyngeal muscle constriction in the upstream, together with fibrosis and relative hypertonia of the cricopharyngeus muscle, there is a outflow tract obstruction. So in this VFSS video, we can see that there is a significant residue retention in the hypopharynx because of the outflow tract obstruction, mainly at the cricopharyngeus level. And for the problem of Cricopharyngeus dysfunction, it is not commonly studied in the literature. Mainly, the focus is on isolated Cricopharyngeus dysfunction, and only one study included patients who has history of head and neck surgery and radiotherapy treatment, having the problem of Cricopharyngeus dysfunction, receiving treatment, which would include using a balloon to dilate the cricopharyngeus, a bougie dilator, or even a urethra catheter balloon. And the outcome is generally promising, where it shows that patient has an improved quality of life, an increased duration of upper esophageal sphincter opening, as well as a reduced in pressure upon manometry study. So we published a study regarding office-based treatment of Cricopharyngeus dysfunction using the balloon dilation method. This is a study which it is a prospective study where we included patients who had a history of nasopharyngeal carcinoma with the treatment of radiotherapy, possibly in conjunction with chemotherapy. And the median time from diagnosis of nasopharyngeal carcinoma to performing the balloon dilation is roughly 15 years. So we would perform a pre-dilation assessment around 20 days pre-dilation and post-dilation assessment 20 days afterwards to evaluate the treatment outcome. So we would select patients using a video fluoroscopic study, and we would like to see patients who have significant residue in the piriform fossa, and to avoid patients who had significant tongue-based atrophy, residue in the folliculi, or abnormal laryngeal sensation and elevation. And many of our patients had other comorbidities such as hypoglossal nerve palsy, unilateral focal cord palsy, and 3 out of our 13 patients had history of head and neck surgery, including nasopharyngectomy and also carcinoma of tonsil with operation. So this is the endoscopic video showing treatment. It is performed in the office with local anesthesia and endoscopic guidance with the laryngoscope. And we use the Cook Medical Quantum control radio expansion balloon, 18 millimeters by 3 centimeters. and the median duration of treatment is around 25 minutes. We would perform the dilation 6 times in totals, 2 times in the right piriform fossa, 2 times in left piriform fossa, and 2 times in the postcritical region. And this is an endoscopic assessment video where we perform before dilation upon Valsalva maneuver. There's limited opening of the Cricopharyngeus. And after dilation, we were able to see clearly the upper esophagus because of the dilated Cricopharyngeus area. And functionally, we could also demonstrate that there is improvement in the reduction of residue in the piriform fossa. On the left-hand side, before dilation, we can see that the patient has a limited pharyngeal pumping mechanism in which there's no whiteout upon swallowing attempts. And there is also severe pooling in the hypopharynx. And on the right-hand side, this is the same patient who again has poor laryngeal elevation and there's no whiteout. But in comparison, we could see that because of the widening of the Cricopharyngeus area, there is much reduced in pooling in the piriform fossa, and therefore reducing the risk of reflux of the fluid and food residue from the piriform fossa back into the airway. So similar outcomes can be demonstrated on the video fluoroscopic study. On the left-hand side, there's significant pooling in the piriform fossa, and on the right-hand side, post-dilation, the pooling has much reduced. So this is our outcome measurements. Basically, for the speed of bolus transfer from oral cavity to the pharynx, it is similar pre and post-dilation as expected. But we were able to demonstrate that upon video fluoroscopic study, the duration of cricopharyngeal opening has much increased by 20% from 0.4 to 0.5 seconds. And most importantly, the penetration aspiration scale has statistically improved by 2 points from pre to post dilation on thin fluid assessment. So what is the penetration aspiration scale? It is a scale to measure the patient's swallowing. For score from 6 to 8, patient would have aspiration, meaning the contrast would pass through the glottis into the airway. As for penetration, it means that the contrast only contacts the vocal folds without entering into the airway. So by reduction of 2 points of the penetration aspiration scale, it means that certain patient would be rendering into a penetration state from an aspiration state. So this is the overall results of our participants. I would like to draw your attention to the aspiration group of patients. On the left-hand side is the pre-dilation. We have 5 patients who were aspirating, and after dilation, only 1 patient is aspirating, and many of them become into a penetration state. On the other hand, we also measure the patient's quality of life with the MD Anderson Dysphagia Index. It is a measurement of the patient's quality of life in the global, emotional, functional, as well as physical status. So the overall results demonstrate that there are statistical improvements in patients' quality of life in multiple aspects, including global, emotional, and performance status. So in summary, Cricopharyngeus balloon dilation is a very useful treatment for patients who had dysphagia with post-irradiation. But most importantly, the problem has to be Cricopharyngeus dysfunction. And with good patient selection, we would be able to demonstrate that there can be a significant improvement in the swallow mechanism, where there's an improvement in the duration of Cricopharyngeus opening, a lower penetration and aspiration scale, as well as an improvement in their quality of life. This is a very safe and short office procedure, and it is well tolerated by patients. Thank you very much for your time and attention, and I welcome any questions. Thank you.